Hello, Laventa.
Hello. Oh, good evening, guys. How are you? Can you hear me, Dr. Anviola?
Yes,
So,
yes,
today we're going to do introduction to pediatrics, how to navigate pediatrics during internship period. And I am Dr. Achieng Laventa, and I am an MO intern at Nanyuki Teaching and Referral Hospital. And today our guest will be Dr. Ann Viola Lalugala, who is a medical officer pediatric in AIC Kijabe Hospital. I hope you guys can still hear me, right? So, our guest, who is Dr. Anviola Lalugula, did MBCHB, a dedicated pediatric medical officer with over a year of experience at Kijabe Hospital. She completed her undergraduate medical training at University of Nairobi, where she developed a strong foundation in pediatric care. Dr. Ann is passionate about providing quality healthcare to children, ensuring their well-being and positively impacting their lives. Welcome, Dr. Ann Viola Nalugala, and let's hear from teachers more on how to navigate pediatrics. Thank you.
thank you so much, Laventa. I hope you guys can hear me. Unfortunately, I don't have earphones, and I was in a bit of a rush to try and make this session today. And thank you for all the participants who joined me today. So I'm just a medical officer. I'm not a pediatrician at the moment, but I've been blessed to be able to practice in Kijabe Hospital over the past 1 year, and I've been attached to the pediatric rotation, and I aim to hopefully do pediatrics as my master's. So I think I can proceed and just start.
Yes, you can start. You can start. And anyone who will have a question, kindly post it at the question box. We'll be at the end of the session. We will read it and you'll be answered by the Daktari.
Okay. So welcome to the rewarding and dynamic field of pediatrics. It is not just about treating illnesses, it is also about fostering healthy growth and development, advocating for the children's well-being, and supporting families through various stages of their child's life. So an overview of the topics I want us to go through. So I was asked to just give an overview of pediatrics. I hope eventually we'll be able to do some of these topics in depth, but I just want us to get a basic understanding of the growth and development, physical examination, common pediatric illnesses, immunization, nutrition in pediatrics, some pediatric emergencies, behavioral and mental health, preventative care, ethical and legal considerations, chronic conditions in patients, some pediatric pharmacology, communication with the families and children, and the special population. It seems a lot, but I've really tried to summarize as much as possible. So I'm sure we are all very, we know how to take history, but pediatric history taking usually involves gathering comprehensive information about the child's health, development, and the environment, unlike in adult history. It often requires us to input from parents or caregivers, and it must be tailored to the child's age and developmental level. You have to obviously get the chief complaints, that by identifying the primary reason for the visit, because you don't want by the end of the visit the parents go and you've not even tackled what their primary reason to come was, right? Then we go on to the history of presenting illness, explore the onset, duration. You remember the Socrates mnemonic that you used to do, include any associated factors, and especially in pediatrics, because most parents walk from hospital to hospital to try and gather information and try to seek help for their patients. Look for any previous treatments and whatever management they were on. Past medical history, we know about birth history, very important in pediatric population. Any previous illnesses, any hospitalizations, surgeries, and immunizations. Developmental and nutritional history, assess developmental milestones and compare them with age-appropriate expectations. family history. You need to gather information on any hereditary conditions, especially for some things like metabolic issues, metabolic acidosis, and such things. Some compromised children can have some issues as well. Family structure and any relevant social dynamics. Then social history, you need to understand the child's living situation, school performance, and exposure. Remember that pediatrics tackles from birth all the way up to 18 and in some instances up to 21 years. So social history is very important. And then review of systems, of course, perform a systemic review because sometimes the parent might have forgotten to tell you something, but when you review the systems, you can be able to make sure that you've covered anything and you have any additional symptoms that you may not have covered when you were taking the initial history. We'll go to the pediatric physical exam. It requires a friendly approach, adaptive techniques to the child's age and comfort level. The way you examine a neonate is not the same way you're going to approach a 2-year-old, and it's not the same way you're going to approach a teenager. So you have to be able to adapt various techniques and establish rapport with both the child and the caregiver before starting. If you don't establish the rapport, it will be very difficult for you to proceed. Go on to the general examination, begin with observation of the child's behavior when the patient is with the caregiver, their appearance, their interaction with the environment, because that can also tell you a lot. Don't just go and bombard the patient with your stethoscope, And then the vital signs, measure temperature, the heart rate, respiratory rate, and blood pressure, considering age-specific normal ranges. So this is something very beautiful, but it can also be a nuisance in pediatrics. Everything is age-specific. So you have to always refer, as that's why I'm saying it's very beautiful because you don't need to cram everything, but everything is age-specific. And then the growth assessment, this is actually very, very important for every patient that you meet. Plot their height, plot their weight, the head circumference on the growth chart, and assess their overall growth patterns. Because the way you manage a malnutrition child is not the same way you're going to manage a well-nourished child. The way you manage a patient with cerebral palsy is not the same way you're going to manage a patient with autism. Sawa sawa. And then you go to head-to-toe examination. This is usually the best way to examine a child because you ensure you have not missed anything. Conduct a systemic exam starting with less invasive areas, for example, the heart, the lungs, saving potentially distressing exams, for example, the ears and mouth for the last. Sawa sawa. And then the neurological status, assess reflexes, tone, developmental milestones. Developmental milestones are extremely important in pediatrics because once you catch the developmental delays early, you can be able to tailor your management specifically for that child. Then cardiovascular, listen for any murmurs, any abnormal heart sounds. Respiratory, evaluate the breath sounds and any work of breathing. If a child has increased work of breathing, the management will be different compared to a child who has normal work of breathing. Abdomen, palpate for masses and make sure again to be very friendly and use some techniques to do this. Palpate for tenderness and organomegaly. And again, you have to be very, very wise as you're doing this because sometimes the child is just afraid of you and everywhere you touch it's painful. So you have to be creative as you're examining the children. Musculoskeletal system, you check for any deformities, do a range of motion, joint stability. For example, children with cerebral palsy, you'll notice that sometimes they present late in onset and cerebral palsy is usually a musculoskeletal issue. So you might find a child who has increased tone and you can give some medication to help with that. And then skin, inspect for rashes, lesions, signs of dehydration, and or jaundice. And on the skin as well, I usually recommend you just make sure you check the diaper, especially for the younger babies. It can be as you can be able to see signs of neglect in babies by just checking the diaper for any diaper rashes, any signs of anything that does not seem right. Okay. For growth and development, remember children are not simply small adults. Their bodies and minds are constantly growing, changing, affecting how diseases present and how the treatments work. So understanding developmental milestones is crucial for assessing a child's health and identifying the potential issues. On this other side, I've put a small chart on the milestones and what to expect between 1 month and 24 months. As I mentioned before, pediatrics is very beautiful in the sense that you are allowed to refer. So if you're not sure about anything or if you think a child is developmentally delayed, then you can just refer and confirm that the child is either within the normal range or developmentally delayed, and then you can manage as needed. So now identification and management of common illnesses. We will start with respiratory infections, which are the most common actually in our setting, especially the upper respiratory tract infections. The most common ones are bronchiolitis, pneumonia, croup, and asthma exacerbations. So you need to identify the symptoms, which usually include cough, fever, nasal congestion, and breathing difficulties. Listen for abnormal breath sounds, such as crackles or wheezes. Then under management, it is usually dependent on whatever you have found on your history taken and on examination. For example, most of the upper respiratory infection is just supportive care, hydration, and antipyretics. And now this is where communication comes into play because you see the parent has brought the child to hospital and they're expecting antibiotics, they're expecting fluids, they're expecting the most. So you just need to tailor the care to the patient and communicate to the parents that they don't really need a lot of management at that point. For bronchiolitis as well is often supportive with oxygen if needed, but there's no need of managing bronchiolitis with antibiotics because most of the times bronchiolitis is caused by viral infections. Now, when we come to pneumonia, we need antibiotics for bacterial cases and supportive care for the viral. But you can also differentiate between bronchiolitis and pneumonia based on X-rays. When it comes to croup, you will need humidified air, corticosteroids, nebulized epinephrine for severe cases, asthma, inhaled corticosteroids, bronchodilators, and a clear asthma action plan. So some of these are a bit more complex. For example, in asthma, I don't think we will have time to go into detail. In case I get another chance, I will be very happy to go through management of asthma, the acute phase, and the continuation phase of management. Then we move to gastrointestinal issues, one common presentation that patients usually present with. So they can come in with gastroenteritis. So this is vomiting and diarrhea. Sometimes it can just be vomiting, sometimes it can just be diarrhea. They can come in with constipation, and they can come with gastroesophageal reflux disease. Identification is very important. So symptoms include vomiting, diarrhea, abdominal pain, and changes in stool patterns. Management for gastroenteritis, number one is hydration. So dehydration is a very, very common thing in children. And sometimes when patients have gastroenteritis, they can present late. So hydration is very important, depending on the stage of dehydration that the patient is coming. If the child is stable, the child is able to feed, you can just start with oral rehydration. If the child is not able to feed or has not fed for a while, you can start with IV hydration. Then you have to have maintenance fluid because there's no need of hydrating a patient in the first stage and then you forget for the maintenance. So maintenance hydration and monitoring for any signs of dehydration. Because you see, children, they're not small adults. They can deteriorate at any point. So it needs and requires very close monitoring. Constipation, yeah, you can need dietary changes, increased fiber and fluids. You can refer them to a nutritionist if there's one nearby. Stool softeners and or laxatives as needed, but you don't really recommend laxatives in children because again, there's the risk of dehydration. So unless it's really, really necessary and required, then you can order for laxatives. And then GAD, you can use dietary modification, positioning strategies, especially when feeding, and in severe cases, you can give the acid suppressing medication. I hope we're together up to that. Are we okay?
We are okay. We are okay.
Okay. We can move on to the infectious diseases. Common illnesses, especially in our setting, are things like malaria, HIV, tuberculosis, acute diarrheal diseases, respiratory infections, including pneumonia and measles. So identification is usually symptom-based, vary by diseases, but generally include fever, weight loss, cough, diarrhea, and respiratory distress. Specific signs include seizure in severe malaria, chronic cough and weight loss in TB, and characteristic rashes in measles. Another thing I can just mention under infectious diseases, especially when it comes to TB, don't expect like a 6-month-old to come with chronic cough. They've only lived for like 6 months of life, and don't expect them to come with like severe weight loss. So what you'll notice is they can present with failure to thrive, and maybe they've been having an on and on cough, needing antibiotics but not going away. Most of these children are usually diagnosed with pneumonia, but it's not necessarily pneumonia. So when it comes to TB for the babies, we don't really do it like the adults, where you have to do like a gene expert has to come back positive. We have leeway to be able to start on presumptive management. So that is just something that you can have at the back of your mind, but it's also in the pediatric protocol. And then under management is usually just disease specific. For example, for malaria, you can confirm with a rapid diagnostic test if you have it, or microscopy, treat with artemisinin-based combination therapy. Severe cases can require IV artesunate, and prevention includes insecticide, treated bed nets, and indoor residual spraying. So as you're discharging the patient, remember to inform them about the preventative measures. For HIV diagnosis, usually diagnosed with PCR in infants, antibody testing in older children, initiate antiretroviral therapy as early. So at the point of care, when you meet this child and you find out that the patient has HIV, you start antibiotic. If it's a neonate and the patient is HIV exposed, you start on the antiretroviral therapy as advised by your CCC team, and provide cotrimoxazole therapy to prevent opportunistic infections, again as advised by your CCC team. I've already spoken about the tuberculosis and acute diarrheal illnesses. Just identify symptoms like water or bloody diarrhea. This will also depend help with the management, because it's watery, it's just hydration. If it's blood, you have to consider other things like dysentery. Manage with oral rehydration solutions, zinc oxide supplements, antibiotics for bacterial causes, and prevention include hand washing, safe water and water vaccination. Under respiratory infection, we've already mentioned the identification of symptoms like fast breathing, chest swelling, drawing, treat with antibiotics that are, so we have to also be very judicious with how we use our antibiotics. For the severe cases, you need to refer, and you can also give IV antibiotics. So this is something I'm really, really passionate about. If you are in a facility that you know you cannot escalate care, please don't waste time, because these babies, they can deteriorate like in the snap of a finger. Sawa sawa. So if you feel like that patient might need some other supportive management, like mechanical ventilation or CPAP management, just refer to a facility. Just do early referral before the patient deteriorates. Because once the patient deteriorates, most of the referral centers don't usually accept a very sick patient. So when you feel like this patient might start or looks really sick, just do early referral when they're stable, so that as they can deteriorate in a center where they can be helped and care can be escalated. And then measles can be identified by high fever, cough, conjunctivitis, and spreading of a maculopapular rash. Usually just need supportive management, vitamin A supplementation, and the vaccination is key to prevention. Skin conditions, most common is usually atopic dermatitis or eczema, impetigo, and diaper rash. What I usually do sometimes, at least once a week, I go through the rashes, because they're very, very common, and parents really complain about this because it affects the beauty of their children and all that. So there are some rashes that you should be worried about, and there's some rashes that you reassure the patient. So you can just do like a day, you just go through a rash. If you're really, really interested in pediatrics or dermatology, it really helps, especially when it comes to reassuring the parents. Identification, you just look for any red, itchy, scalpy rashes, honey-colored crust like in impetigo, and inflamed skin in diaper areas. Management depends on the type of rash that you have. For example, atopic dermatitis, emollients, topical steroids for flare-ups, and avoid triggers. So this part for topical steroids, I'm going to try and kusisitiza kidogo. Don't give all baby steroids. Sawa. Some babies come to the clinic, they're very brown on the face with very black ears because they've just been on steroids for most of their life. Just give everyone steroids. Give steroids as needed, and then give steroids and give them a duration of time where they use. They should not just use steroids for the rest of their lives. Like prescribe when needed and prescribe the duration, and make sure that the mom understands the side effects of this infection, this treatment. For impetigo, topical or oral antibiotics, depending on the extent of infection, and it is usually has this honey-colored crust. And then for diaper dermatitis, frequent diaper changes, barrier creams like zinc oxide, and antifungal treatments if candida is suspected. Febrile illness is another very common presentation. Patient just arrive in the hospital with just fever of unknown origin. They can have viral exanthems and urinary tract infection. Most urinary tract infections actually just present with fever. Some can even present with some respiratory features. So identification, fever with or without accompanying symptoms such as rash, irritability, or urinary symptoms. Management of the fever with antipyretics, viral exanthems would be supportive and symptom management. UTI, you will diagnose urinalysis and culture followed by appropriate antibiotics. And note I've said appropriate antibiotics. Don't just give antibiotics and you've not cultured. So make sure you're doing with the appropriate antibiotics so you'll be good with our antibiotic management. Under allergic reactions, allergic rhinitis is very common, food allergies and anaphylaxis. Identify symptoms including sneezing, runny nose, hives in severe cases, difficulty breathing and swelling. Management, you can use antihistamines, nasal corticosteroid, avoid allergens if it's allergic rhinitis. Food allergies, you need to identify and avoid the trigger foods with an action plan for accidental exposures. So some people with like very serious food allergies, you can advise them to be working with EpiPens, but that is not as common in our setting. And then anaphylaxis, immediate administration of epinephrine and emergency medical care. So pediatric emergencies, we need to be able to know at least basic life support. About the advanced pediatric life support, you don't necessarily need to know, but if you know the basic life support, you can be able to sustain a life until someone more senior can come and assist you. So we need to know when to identify an emergency, when to call for help, how to initiate CPR, how to manage airway, how to treat shock in children. And most of the time when children present with shock in our setting, it is sepsis unless proven otherwise. So the common pediatric emergencies are usually management of shock. Under management of shock, you need to understand if the patient has shock and is well nourished, or the patient has shock and is malnourished, because the management becomes different. We need to know how to manage seizures, like the small breakthrough seizures, a febrile seizure, or a continuous seizure, which usually called status epilepticus. We need to know how to manage dehydration. If you manage dehydration well, you will not proceed to shock. But if you manage dehydration poorly, you will proceed to shock. So how you manage these emergencies are very important. We need to know how to manage DKA, when to start insulin, how to start the fluids. So these are the common pediatric emergencies, and then foreign body and trauma. Poison and toxicology, we need to know the common toxic substances in children and their management, but this is now just based on how the children will present. But the upper bulletin where we have said shock, seizures, dehydration, DKA, foreign body and trauma, these are usually very important. And let's not forget also the oncological emergencies, which I didn't put there. Then we have behavioral and mental health. So we need to know how to manage issues like temper tantrums, disturbances, and ADHD, as well as autism, which has become a common diagnosis in our children in this setting nowadays. Mental health concerns, recognition and initial management of anxiety, depression, and autism spectrum disorders. Also, don't expect just teenagers to have anxiety and depression. Smaller kids can have anxiety and depression. Recently, I had a patient who was really like less than 10 years old and was admitted with severe anxiety, borderline depression, and it's just issues at home. So don't just like rule out anxiety and depression for bigger children. Even smaller kids can have it. And that's why under history, the social history is also very important. And then we have the adolescent mental health, addressing issues like eating disorders, not really common here. Our problem is not actually eating disorders, it's malnutrition because we don't have enough food. And then substance abuse and peer pressure. Then preventative and health maintenance. So once we manage these problems, we need to also have like well child visits, what to cover and routine checkups, including screening tests and anticipatory guidance. So also as you're discharging these children from their visit, whether it's an outpatient visit or it's an inpatient visit, make sure that you inform the mom about the danger signs, anticipatory guidelines, so that if an occurrence happens that can be concerning, they can come to hospital in time before waiting for the child to deteriorate. Oral health is very important, importance of dental care and prevention of any dental caries, injury prevention, counseling on safety measures, including car seats, helmets, and home safety is very important. Then now we have ethical and legal considerations in pediatrics. We need to understand who can consent for a child's medical care and when to assent for the child from what the child is needed. Confidentiality is very important. Issues related to privacy, especially in adolescent care. There are some things that a patient can tell you that they don't want the parent to know, and you have to use wisdom to decide what to tell the parent, what not to tell the parent. And as I said, in pediatrics, sometimes you're not really just treating the child, also treating the family and the mother. Sawa sawa. So sometimes the mom knows that this child is not the dad's and they don't want you to share their blood group. So confidentiality is very important. These are things you meet huku nje. Aya. Then reporting obligations, legal requirement for reporting child abuse, neglect, and certain infectious diseases. I had mentioned earlier, checking the genitourinary tract is very important, especially when it comes to abuse. So if you note there is abuse, you can try and speak to the child, but most of the time they will not be able to talk. Escalate it to the necessary people like a social worker or a pediatric counselor or a pediatric, just someone who can be able to help the child to open up. And then if there's need for any legal intervention, then it can be done as needed. Please don't discharge a child who you think is being abused at home. That is really, really unfair because you're just returning the child to the same cycle of abuse. Then we have some chronic conditions. As I said, some things like asthma and diabetes and congenital heart diseases, it will be really hard for me to be able to just talk about all their management in this session. But if I get another time, we can go through them. But you need to understand, for example, in asthma, understanding the triggers, medication needed, and the action plans. For example, if you have an asthma exacerbation, what are the next steps? When should you seek help? When should you go to the hospital? And if you're the one who is managing, when should you escalate a plan? And then for the diabetes, we need to know basic management of type 1 and type 2 diabetes. Nowadays, when children come, don't just assume that the child has type 1 diabetes because of all these environmental changes that we have. Some can have the type 2 diabetes. And remember that the management is usually different. So we can use insulin and use of blood sugar monitoring and fluids. And then congenital heart diseases, overview of common congenital heart defects and their management. And a pediatric pharmacology, I remember when I did my pediatric rotation in internship, this was the worst thing ever. Because everything is like dose per kilogram. It's not just like in adults where you can say, PCM, give them 1 gram, you know. For children, everything is dose per kilogram. So dosing and drug safety is very important. Understanding the age-appropriate dosing, the side effects, and medication errors. Common pediatric medications, you have to know them. Like right now, I can say PCM 15 milligrams per kg per day. Because in an emergency setting, sometimes, as much as I said, pediatric is beautiful and you can refer at any time. Can you imagine an emergency situation? I'm supposed to be doing a resuscitation. The nurse is asking me for a medication, and then I go start looking for my book to look at the pages. It doesn't really make sense. So we need to know familiarize with the commonly used drugs, including antibiotics, antipyretics, vaccines, and the resuscitation medication. Actually, the resuscitation medication should come first. And then the adverse drug reactions. As you give this medication, remember that there are chemicals that enter the body. Some people can have some allergic reactions. Some people can have just adverse drug reactions. So you need to have those adverse drug reactions at the back of your mind, identify and managing these drug allergies and any other reactions as needed. And then now we come to the special populations. Care for children with special needs. We need to understand the unique challenges that these children face. and the care requirements for children with physical development and or cognitive disabilities. The way I will manage a 2-year-old who is normal is not the same way I will manage a 2-year-old who is neurodivergent, that is, who maybe has autism or ADHD or something like that. So, the way I will manage a 10-year-old with cerebral palsy is not the same way I will manage a 10-year-old who just comes with a cough. So we need to understand their unique challenges, because they're not going to be like normal. They will have difficulty feeding, difficulty growing, recurrent infections, and they need compassionate care as you are managing them. And then adolescent medicine, addressing the specific needs and concerns for teenagers, including sexual and reproductive health. Are we together up to there?
Yes, we're together. We're together, Daktari.
Okay. Now, I feel like I've gone quite fast. It was supposed to be a 1 hour, 30-minute session, but I'm on my last slide. So some of the tips for success that I used during my pediatric rotation, some of the things that made me love pediatrics at the end of the day, you need to stay curious. Try to continuously expand your knowledge and stay updated with the latest guidelines and research in pediatric medicine. Don't always depend on the consultant. In some facilities, I'm very lucky in my facility, our consultants are available, but in some facilities, you don't have the consultant. You are the first and the last person. Everyone, kila mtu anakutegemea, si ndio? So you need to continuously learn, try to expand your knowledge. You can use resources like UpToDate, AMBO, so just read the NABP research things, just try to know the latest guidelines. Be compassionate. Always try to be compassionate. Imagine if you are a mother and you're bringing your child and someone is just treating you like, because the mother is worried, the child is sick, So always try to show empathy, understand towards your patients and their family. Sometimes a mother can come, but they're frustrated. They're trying to talk to you, but how it's coming out negatively. But if you're compassionate and calm, they also become calm, and then everything is just okay. But if the mother comes, ako huku juu, you come, you also huku juu, the care will never be the same. And we said pediatrics, you need to advocate for the patient at the end of the day. You're the champion for this patient. So if the mother is not okay, the baby can never be okay. A kind approach can significantly influence a child's healthcare experience. Then develop strong communication skills. Learn to communicate effectively with children for different ages and backgrounds. So I am very notorious for this. I like wearing bright colors. I'm usually kind of a bit extravagant. I will have toys in my pocket. My phone cover is like a doll or a cat, or make sure you have what is it called? Baby shark, like on speed dial, like such things, for different ages. And then you can't use baby shark on a 13-year-old. You look very stupid, So you need to know how to develop strong communication skills for different ages, backgrounds, as well as their families and healthcare team members. Then you can also seek mentorship. Mentorship is not an easy thing to get. Trust me, I really try to get mentors. And sometimes you just don't connect with the people you meet with. But if you connect with someone, unamshikilia kama kupe. Because at the end of the day, when you engage with experienced pediatricians who can provide guidance and support and valuable insight into the field, it will really help you with also your morale and just how you also engage in the day-to-day activities. And finally, reflect and self-care. You need time for yourself at the end of the day. Internship is hard. Let me tell you guys, internship is really hard. And especially Sahi, when you're not even sure whether you'll be paid or not, it is even harder. Because I remember I will be like crying, especially in my obstetric rotation. I will cry. And then I see KCB message has come and then I get rejuvenated, rejuvenated energy. So just remember that internship is hard. You need time to reflect and have self-care. Self-care is very important, people. Si kujipenda ati sasa unaonyesha uko high class, hapana. Self-care is very important for the females out there. If you have time to go get your nails done, go do that. If you have time to go hike, go do that. Take time to reflect on your experiences and prioritize your well-being to maintain a healthy and sustainable career. Because at the end of the day, if the doctor is not okay, the patient can never be okay. Thank you for listening to me. I really try to make this session short because I manage pediatrics and I have short attention spans and I didn't want you guys to get bored. I'm going to give it back to Laventa to continue with the session. Thank you again.
Thank you so much, Anviola, Daktari. It was so inspiring. We've really learned a lot. And anyone with a question, kindly post in the chat box. We'll read and let Daktari answer. So let me start with my question, Daktari. When it comes to blood transfusion, where I am right now, like they'll give you a whole of the 450 ml unit of blood, right? So I was wondering, like you just need a very small, very little blood, and that you've been given 450 ml. So you're like you're going to waste most of like a half or three quarter of this blood, because once you've transfused the blood, then the rest cannot be given to any other person. So how do we go about it? Do we have the smaller bags? Is it that we have the smaller bags and the hospital I am in doesn't have the smaller bags? Second thing, I'd really love you to host a diabetic session, how like the insulin and rehydration of the in pediatrics ward. So yeah, I'm so much interested in this session.
Thank you for that. So I'll start with the first question regarding blood transfusion. Yes, it's really hard when you need to transfuse a patient and then you're given this like a whole half a liter of blood. And for example, if you're blessed enough to work in a NICU, maybe they just need like 10 cc of blood. So what we do in our facility, when we order for blood, we also order for like these syringes, like the 60 cc short tip syringes, and then also with a perfuser. So when you go for the blood in the lab with that container for blood, they just withdraw blood from the bigger bag. So I don't know if it is something that maybe you can incorporate in your facility. So whatever the blood is in the big bag, they just withdraw the amount of blood you need and then you're given and then you give. But now you see in our facility, in our setting, we have the pump. So I don't know if it is plausible in other facilities, but maybe that is something to consider. Regarding the diabetes topic, I would very, very much love to give a presentation in diabetes because when we know how to manage diabetes really well, we can save so many lives and we can prevent further deterioration. So if you give me that chance, I would love to do that.
Okay, thank you, Daktari. Another question is for a pregnant mom with after the ultrasound, obstetric ultrasound, you find that the baby has hydrocephalus. What's the best way to deal with this? Should we refer to the mother to a facility where after the delivery we'll have the shunts put in place immediately, and then now we're going to deal with finances later, or should we just deliver the mother like over postdatism? Should we deliver the mother who is on postdatism and after that then refer to facility where the baby can get that shunt? How do we go about it? Because where I am, like there's okay, I've seen such cases where the mother comes postdatism 42 weeks. Now you don't want the baby to be inside, you want to deliver the baby, but the obstetric ultrasound shows that the baby has hydrocephalus. How do we manage that?
Okay, so if the baby has hydrocephalus and is unable to be born via SVP and it's postdatism and you want to perform a CS, I think you can still proceed and do that. However, early referral is important because I'm imagining, because this child is postdatism and at the point when you're meeting them, they have a heart rate. you can refer them, and maybe they don't have money to go to another referring facility, or they just don't understand the urgency of the situation or whatever. So I don't really think there is need to refer a baby in utero if you can be able to help them if they're not a pregnancy, because postdatism will kind of fighting with time, and then you can later refer to a facility that can manage hydrocephalus. But if you're comfortable that the baby is safe so far in the uterus and they can be able to go to the next facility, then I advocate that you just refer early enough. But I know, for example, in Kijabe, we accept patients who have hydrocephalus, and we do shunt placements, just depending on whether the type of hydrocephalus they have requires a shunt or not. But I think it will just depend on how the patient presents and what you think at that time.
Okay, Daktari, thank you for that. I'm looking at the chat box. I'm not seeing any other question. And my last question will be, when it comes to putting an IV line, hey, challenge, and you end up pricking the chest several times, and you feel so empathetic and sympathetic at the same time. And you also want to know because you want to learn. So it's like, which one should I choose? I know that's not, it's not that much important, but now we are in such a place where you're hurting the child, and then at the same time you also want to advance your skills. You see? Yeah. So how would you advise on that?
That is a good question. Actually, pricking is one of the things I really don't like in pediatrics, especially when the baby cries and then they look at you with very, very cute big eyes, especially when they're tearful and you just feel sad. It's usually very, very sad. But if you will allow me, I will answer this with a small story. When I was in my third year of medical school, one day I was just, unajua tukiwa third year vile uko na cycle, you've just started your medical rotation, so you want to start taking history. You're from the, umetoka, like for the example, people from UN, you've just come from Chiromo, now in the world, you feel like a small doctor. So there was this baby I was taking history for presentation during rounds. And then that weekend, I had just gone to the ward, and fortunately enough, I had met a resident who had just talked to me about shock. So this baby was in shock, but again, it was my first day in pediatrics, so I don't know how to identify these things. So the baby was there breathing with very, very bad work of breathing now that I think back, and barely conscious, and I was very busy asking how the mom cooks at home, if they use firewood and or they use gas, very relevant questions for that time. And then this baby just stopped breathing. So the first thing that came to my mind, honestly, I'm not even sure how shock came, but I think because that other doctor had mentioned shock, I touched the baby had cold extremities, and the first thing that came was, oh my goodness, shock. So I just rushed and called the consultant who was about to start on, and they came, and for sure the baby had shock. And eventually we had to prick that baby many times, try to intubate that baby, do CPR, do everything we can, putting boluses to the IO, nini, and all that. So once we were finished, I remember going to the resident and asking them, oh my goodness, doc, did they hurt the baby? Because what had happened was I had told the mom to turn the baby, and then so that I can examine the chest. And then when the mom turned the baby died. And then she told me, if we don't do it, who will? And if we don't hurt them, how can we help them? And that really stuck with me. So sometimes as you're trying to prick that baby, remember, like maybe this baby is dehydrated, you're trying to prevent them not to go in shock syndrome. Maybe this baby has an infection, you're trying to prevent them not to get into sepsis. So sometimes you have to hurt them so that we can help them, but also practicing makes perfect. I'm not the best person to actually prick people. Facility Niko, Bahati is we have people who come and take some blood samples. We have our nurses who put cannulas. So by the time you're being called, you're just being called for maybe an IO or they need a CVC. So we don't really prick them that much, but sometimes you have to really, really prick them because at the end of the day, you are hurting them, but it's for that you can be able to help them.
Thank you for answering that. At least you've given us hope that you have to ask them for you to help them. If you don't do that, then who else will do that? Thank you, Sana. Daktari. There's still no other questions in the question and answer chat box. So on my end, I think you've answered all my questions, and I hope everyone is satisfied. There are those people who are raising their hands. I'm sorry, I'm not unable to give you the mic, but you can type. Oh, there is one question here. There is Beatrice Mwangi who is thanking you, Dr. Anviola, for the informative talk. Yes, everyone else can also type and thank Anviola, or you can ask questions. She's here to teach us today. She's here to give us the information, and we are the receivers. There is an anonymous attendee saying that it was a good presentation, Dr. Anviola. No any other questions. So I think we'll be done for today. And thank you so much, Anviola. I think May will find another time and we'll invite you and do other sessions in pediatrics. I've realized that pediatric is so big and it needs a lot, and we really need the knowledge to help the patients who are kids. And thank you again. And we had I enjoyed it. I'm well informed compared to how you found me, and I think I'll decide if I want to be a pediatrician, not right now, but after internship. Thank you so much.
Thank you as well for inviting me, and I look forward to more sessions with you. I love pediatrics so much, and the more people love pediatrics, the better our babies will be. So I really hope you will decide to join us on this side.
So everyone, thank you for coming. Thank you for attending. Thank you, Dr. Anviola, for teaching us, and let all of us have a good evening.